Welcome to the fourth event in the recovery stream of the 2022 Healthy Working Lives seminar series, focusing on the COMPARE project. There'll be another 2 free seminars between now and June. In the spirit of reconciliation, we acknowledge the traditional custodians of the country throughout Australia and their connections to the land, sea and community. We pay our respect to their elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islander peoples today. My name is Associate Professor Ross Isles from the Healthy Working Lives Research Group at Monash University, and I'll be your MC for today's event, New Insights into Healthcare Use in Australian Workers' Compensation Schemes. In today's seminar, we have Professor Alex Colley, Director of the Healthy Working Lives Research Group, and Dr. Mary Wyatt, Occupational Physician. Alex is an applied public health and social policy researcher with a focus on work disability, workers' compensation, injury recovery and rehabilitation. He leads a number of large multidisciplinary and multi-institution research projects focused on improving worker health, supporting return to work and preventing work disability. As well as leading a very talented research team in the Healthy Working Lives Research Group at Monash, Alex holds an Australian Research Council Future Fellowship and is the current president of the Scientific Committee on Work Disability Prevention and Integration for the International Commission of Occupational Health. Mary's work in injury management spans decades and has included running an early intervention case management approach across a number of large employers and running returntoworkmatters.org, a non-profit seeking to share evidence-based practices that support better return to work. Mary also works as a treating practitioner, conducting a state-based review of return to work for a regulator and advisory work for various insurers and regulators. There will be a question and answer session at the end of the stream, but throughout the seminar, you can submit questions via the Ask a Question button, which appears below your live stream. So please feel free, if you've got questions, drop them in and we'll cover them at the end of the session. So over to you, Mary.
Thank you very much, Ross. It's a challenge to talk about healthcare for work injuries in 15 minutes. So here is my run through. The first key issue that we need to deal with is that when a health condition, an injury, is under a compensable system, our outcomes are worse. And this is the same whether we have an everyday back problem or a significant issue that requires surgery, happens for just about all musculoskeletal problems, and we see worse outcomes for people with psychological health outcomes. So today I wanted to use back pain as an example of healthcare in work injury management, initially talking a little bit about what I see as a practitioner. The second thing I'd like to talk about is a little bit about the gap between evidence and practice. And again, I'm focusing on back problems as an example, suggesting that we are not closing the gap between the two. And I think that direction we're heading in is, in fact, things are not likely to improve the way we're going, and potentially will get worse. And then lastly, to talk a little bit about what we can do. Many of you in the audience will be aware that last week we launched the Faculty of Occupational Environmental Medicine College of Physicians policy on work injury scheme management. And we go into quite a lot more depth in that paper. If you Google it pays to care, AFOM, you'll come across it. And if you've got a PDF of this, then you can just link to it. So what do I see happening? Well, this is a sort of a more extreme but typical example. And I apologise, it's not from last week, it was from a few months ago. An everyday guy, a tradie, hurts his back, has treatment, gets back to his normal job. Along the way, his physio treatment plan records pretty high rebro, no one takes any notice. His back pain gets back to his normal job, his back pain gets worse, he gradually shrinks what he does, gives up sport, various things at home, and gets increasingly worried. What's his future? Am I going to be much worse? How will I cope as I age? not getting better, GP refers him to a surgeon, he's got everyday back pain, and the surgeon refers him to a pain specialist. So here's really very much the biomedical model in operation. And this is literally what happened to the chap. Various further investigations, and the pain specialist is now talking about a whole bunch of series of injections and intervention therapy. And lastly, if they don't sort it out, they'll do provocative discography, which is a very controversial, invasive investigation. So very sad to see something like this happen. We are stuck in standard pathways of care. I've used this line a few times, but Michael Francis, CEO of Return to Work SA, has a lovely way of talking about this, and it's that, like gravity, we get pulled back to doing the same way of doing things. And this is very much what happens in back pain. So in the 80s, I was involved with the development of back pain guidelines in Victoria, distributed widely, made no difference. We are still doing the same things we've talked about 20 years ago, and we shouldn't be doing that. There is some variation around the country. I think in some jurisdictions there is a greater focus on advice and explanation and treating the whole person. And there are some excellent practices. And I also want to tip a hat to some jurisdictions and policymakers who are trying to address this issue. So CIRA's looking at value-based healthcare. The TAC in Victoria has recently put out an expression of interest call for people who would like to look at different pathways. ACC in New Zealand is looking at value-based healthcare. Most jurisdictions are struggling with this and trying to grapple with how to deal with it, and some are more advanced than others. But really, if we look at standard pathways, and I'm sure all of you have seen this regularly, the normal approach is let's do a scan, let's send the person to physiotherapy, and if they're not getting better, let's send them to a specialist. We have a standard operating system in Australia that incentivises low value care. So I'm Victorian primarily, and I see the complex patients, and so I have to remember that. But what I'm seeing time and time again is people being referred to a specialist, and that's typically a surgeon, and they'll typically do further investigations, and they might then recommend further interventions. And there's an active intervention group in Melbourne who are seeing a lot of patients, and there's almost an ad at the top of their referral letter saying that they'll see work cover and TAC patients within 2 weeks. Now, what we really want is interventions that focus on advice and explanation, and they are being bypassed. So funding for interventions, injections, surgery is significantly greater per time unit than spending time talking to people. So we're still stuck with the biomedical versus biopsychosocial model. We talk about the biopsychosocial model, we think we do it, maybe people think it's important, but it's actually really challenging to implement. There's an enormous number of steps if we want to implement biopsychosocial on a systematic approach, and we're not nearly there yet. We like quick fixes. This is just life. It's not confined to medicine. We want to look for quick fixes. And so doing something is more likely to give you a quick fix, more likely to feel like you're going to get a quick fix. And so doing things is the model we are operating under. It might be you're a GP and it takes 10 minutes to explain to patients why they don't need a scan of their back. It's much quicker, and patients like it, and doctors like it, and case managers want it to do a scan. And that is a crucial problem. The next step when we do a scan is that we tell people about their results in a way that induces fear. It sounds, a lot of studies now saying that if you talk about degeneration, disc bulges, disc protrusions, that's a worry for people. They naturally think that's something concerning. And so that then often leads to people focusing more on their problem and being more cautious. Those interventions that I've mentioned, doing things to people, whether it's a lovely hands-on massage, which most of us love, that's doing something to someone, or other sorts of passive treatments, which are doing things to people, patients like them, it's easier. And so that's typically what is happening. I see many people who are being given exercises to do, but it's a bit of an ancillary approach. And really, when you get into it, they're not doing them, and they're not doing them regularly. So a quick run through on my anecdotal stuff. So what's the evidence? Well, I've already mentioned the first dot point. People want advice and explanation. It takes time. It's not happening. Practitioners are fear avoidant, so we tell people to stop doing things. Many clinicians advise activity restriction and time away from work. We've been talking about avoiding radiology for decades. It's still not happening. In fact, it's probably increasing. So the issue in doing investigations, which really seems to start the whole process, is that evidence says that when we tell people about the results of their spinal investigations, they worry more and they do less. So randomized study, those who were given the results of their scans, or everyone had a scan, those who were given the results reported smaller improvements than those who didn't have their scan results. Those with back and leg pain who had scans were reporting poorer health than those who didn't have scans, and they were more likely to want further health care. So we start the process and don't realise the path we're taking people down. A few quick slides on advice and explanation. My favourite study, you may have heard me talk about it before, was from the mid-90s in Norway. Pretty simple advice and explanation, rich storytelling that really gave people an understanding of the nature of their back problem. And on the right, this is a survival curve. So not a comp system, it's a sickness insurance, but everyone was off work at 8 weeks. And those who had this intervention were half as likely as the control group who received usual care to still be off work. And at 5-year follow-up, there was still the same results. So here's an intervention that took a matter of hours, low cost, made a massive difference. It's been repeated, not quite as good in other studies. I think the storyteller in this situation, the doctor was had wonderful storytelling abilities, but still great outcomes. Public health campaign, some of you might remember it from Victoria, messages about don't be frightened about your back problem, strong penetration, expensive campaign, television ads, people knew about it. And what we saw here was a reduction in the number of claims, number of back claims, compared to non-back claims when the intervention was introduced. And there was a reduction in days off work on the back claims here versus non-back claims, and a reduction in medical costs, back claims versus non-back claims. Psychosocial factors, this is the WISE study from New South Wales, early identification of psychosocial factors. So the slide above was talking about a public health campaign reducing fear avoidance. And on this occasion, the psychosocial factors are dealing with coping ability and workplace issues. Would you mind just a moment? Just lots of noise in the background. So in this situation, we're talking about coping factors and workplace issues and other psychosocial issues. And those who received that early psychosocial care had much better results with much long-term disability. So the blue is the control group, and the red, you can see this is amount of time off work and the costs involved. So significant evidence that psychosocial factors and dealing with them effectively can assist. This is a slide looking at the biopsychosocial model from a practitioner in the UK and looking at advice and explanation and really the different approaches that one can use to improve psychosocial and the person's empowerment, really, of understanding how they can deal with the condition. There's a lot in there. You can't see all of this in this time frame, but this is where we really need healthcare to go to focus on this, but it does take time. So why are things this way? Again, I'd invite you to go back and look at the AFOM policy on this, because we go into it in more detail, but we do need to look at the way systems are operating and the various incentives that we are providing, and our incentives are attracting low-value healthcare. When people did not have to pay for their healthcare, this is a study from decades ago, they actually had worse outcomes. So they had more healthcare and worse outcomes. So what can we do? And I'm going to be a few minutes over time here, Ross, I apologise. So what we need is to alter our current patterns of healthcare. This is a massive exercise. I'm not confident we can do that. If we try to restrict what doctors do or healthcare providers do, it's generally ineffective. It's telling people not to do things is often not taken up. If we provide people with more constructive ways of doing things, then we're much more likely to be effective. So we need to foster better pathways. Briefly talk about the CoE Clinics in Washington State in the US. This is a model where practitioners are offered incentives for evidence-based practice. And you can see that there are costs on the left-hand side of the screen, which are incentives or payments for doing things that are evidence-based. So a comprehensive analysis of impediments to return to work attracts a decent fee. The choice of providers in the CoE clinics, and so people can go there. And in fact, the majority of people now do go to those clinics. And I would encourage jurisdictions, particularly those who are thinking deeply about healthcare, to consider this as an option. This is bringing in healthcare providers who are focused on the issues and incentivized to approach in the biopsychosocial way that we need. And here are the references, and I'll hand back to Ross at this point. Thank you.
Thank you, Ross, and thank you, Mary, for that great insight from your perspective of what's going on in our care and treatment of workers in Australia. I wanted to really pick up one of the themes that you mentioned towards the end of your presentation, which was about understanding patterns of care. And what I want to do is spend the next 15 minutes describing a project that we at Monash University in our Healthy Working Lives group have been working on for the past few years, trying to develop methods that give us much greater insights into patterns of care amongst injured workers in Australia, in our workers' comp schemes. The work I'll present has been funded by a range of different agencies and uses data from a range of different jurisdictions, and thank you to those jurisdictions for providing the data to us at Monash. The things I say today are my opinions and don't reflect those of those agencies or funders. Now, just a brief sort of sideways step. I'm going to talk a lot about workers' compensation, and there's one of the messages I would like to give you is this huge opportunity to improve care and reduce waste in care in our workers' comp schemes. But we also, one of the reasons I do this is because by operating through workers' compensation, I think we have an opportunity to make major inroads into what occurs in our population in terms of the burden of disease. So this is a slide from the Institute of Health and Welfare from the last National Burden of Disease study showing the years of healthy life lost due to disability in 5-year age bands. And you can see that the vast majority of disability in our country is in people of working age. And the two major things that contribute to that are musculoskeletal conditions and mental health conditions. And I guess what we tend to see as some of the more common things occurring in our workers' compensation schemes are musculoskeletal conditions and increasingly work-related mental health conditions. So by improving care and reducing disability and improving return to work in people involved in our workers' comp schemes, we also have this potential to make a huge impact on the national burden of disease. There are some really well accepted models around now for how we can improve return to work and prevent disability in workers. And essentially they describe the necessary coordination of care across multiple domains, including workplace compensation systems and the person's own environment. Critical part of that is also healthcare and healthcare systems. And if we want to have coordinated care, we need to understand what care is currently being delivered and how it's affecting the outcomes of workers in our workers' compensation scheme. So that's really what I wanted to talk about today, is this healthcare domain as a critical part of work disability prevention. If we look at what we spend on treatment services to injured workers in our Australian workers' comp schemes, it's quite substantial. The last estimate we have from Safe Work Australia shows that collectively our schemes spend $2.4 billion. And there has been a pretty significant growth over the last 5 years, or over the 4-year period to 2019, 2020, a 26% growth. So it's the second largest area of expenditure, and it's growing very quickly. So there's every reason to want to look at this in more detail. So that's a pretty significant investment, $2.4 billion, but can we really say what we're getting in return for that investment? So I would propose to you that we should be able to answer some quite simple questions, but we can't. So we should be able to answer questions such as, how many times does a worker see a GP during the course of their claim on average, or a physiotherapist or a psychologist? And is that healthcare service having an influence on how long they spend off work or their interaction with workplaces or other things important to that worker? Did that change we made the policy or practice, or that legislative reform, have an impact on the healthcare, the treatment that's provided to workers in our workers' compensation schemes? Are certain combinations of care better than others? If a worker with back pain sees a GP and then has multiple physio visits, is that better or worse than seeing the GP lots of times and the physio once, or other sorts of combinations we might think of? There are many of these questions that we can think of, and at the moment we don't have answers to these because we don't see data nationally. We don't even really see good data transparently across some individual jurisdictions. And that's because we have lots of challenges in the way that we collect healthcare data in our workers' comp systems in Australia. Typically, data sits in silos within insurers or within individual jurisdictions or schemes. We don't have any standards for capturing data or for coding that healthcare data in ways that allows comparison across schemes, across insurers, across the country. And data capture methods vary dramatically. So data gets entered into our into our databases by different people in different ways. And that creates a huge cost in person time at the other end when trying to make sense of that information. We don't currently have any agreement on important healthcare quality indicators. Some jurisdictions are taking a bit of a lead here on getting value-based care indicators, like what's happening in New South Wales and in some other places. But nationally, we haven't really sat down and said, well, we think these markers of healthcare delivery are important indicators of what we're paying for and what is being delivered to injured workers. And we see very limited reporting, and there's very little transparency about what is occurring for that $2.4 billion investment that we're making in healthcare. So what we've been doing at Monash is we've spent the last few years building some data resources that start to answer this question about patterns of care. So with the support of 5 different jurisdictions, and thank you to those jurisdictions immensely for providing your information to us for this project, we have harmonised healthcare data across 5 different systems, and you can see them represented there: Western Australia, South Australia, Victoria, Comcare and Queensland, representing a fairly significant proportion of the population. And we've taken individual payment level and claim level data from each of those jurisdictions, and in summarising 2 years of work in a sentence, we've turned it into a single database, and we've been analysing that database. It's a huge amount of work involved in that I don't have time to go through, but we do have multiple publications and reports describing the process that we've been through to do that. And we call this thing the multijurisdictional database. It's essentially a database of 5 years worth of accepted musculoskeletal disorder claims that were lodged and accepted between 2010 and 2015, with a minimum 2-year follow-up period for each of those claims. It involves over 100,000 cases or claims on this database and over 5 million episodes of health service provision to those people. So it's quite a rich data source. And the information I'm going to be talking to you by coincidence, Mary and I didn't set this up beforehand, I'm going to be talking to you about some studies in low back pain. We have now published 4 studies from this database, and there are many underway. I'm just going to give you some samples of the work we've been doing with this data that start to give us an understanding of patterns of healthcare and what that healthcare is doing in terms of duration of time off. So the first example I'll give you is from a study where we asked a very simple question. This was published late last year in the Journal of Occupational Rehabilitation. The citation for it is at the bottom of the slide. We just asked simply, what's the frequency of general practitioner services in each of 4 states? So how often does a worker with a claim for low back pain go and see the GP? And the answer may surprise you. So the graph on the right says that across these 4 states, the average amount of times is 10. But you can see there's huge variation between the jurisdictions. So in Queensland, the average is nearly 6. And in South Australia, the average was 16. And we see different numbers in other states. On the left, what you can see is just some slides showing the proportion of workers with low back pain and the number of times they see the GP. So you can see those distributions are quite different. In this paper, we tried in multiple ways to select samples from with each of these jurisdictions to match the claims as closely as possible, because we know that the people who get into some schemes have different features than others. So we run the same analysis in 4 different cohorts, each analysed defined in slightly separate ways to try to make them look as similar as possible between states. And we still get these big variations in the number of GP services per claim. So this sort of begs this question, I think, is why are workers in Queensland receiving fewer GP services and for shorter periods of time than workers in other jurisdictions? And you can think of lots of different reasons why that might be occurring. We know there are different approaches to requirements for medical certification around the country, and it just so happens that in Queensland, the requirement for medical certification is quite different to what we see in Victoria, Western Australia and South Australia, where workers are often required to go back to the GP on a monthly basis in order to get a certificate to allow them to continue to receive their income support benefits. It may be that there are different approaches to treatment and rehabilitation in those jurisdictions. It may be that differences in things like eligibility for compensation playing out in the data that we see, although we did try to, as I mentioned, control for that as much as we possibly could. The short answer is we don't know, but it's a question worth asking. We probably need to know more because we're seeing this huge variation in care delivery in what is probably one of the fundamental aspects of healthcare across those 4 states. Here's another example with that general practice data where we've looked at what's called continuity of care. And so this is simply whether a worker is seeing the same GP during the course of their claim, or if they're seeing different GPs during the course of their claim. And there's good reason and good evidence to suggest that more continuous care that is going to see the same healthcare practitioner might lead to better outcomes. So what we have done here is applied one of the sort of multiple accepted metrics for continuity of care to workers' compensation data and broken groups into complete continuity of care, which is on the left-hand side of this colourful graph, all the way through to low continuity of care. And low continuity of care would indicate that you're seeing lots of different GPs during the course of your claim. This is data from 3 states, pooled from Victoria, South Australia and Queensland. And we see some things that are associated with differences in continuity of care. So things like older age, where you live. So there are some differences between states here. Remoteness and occupation were all associated with differences in continuity of care. In this colourful slide, what you'll see is where people live in terms of if they're living in a major city, a regional area, or a very remote area. It has a sort of significant impact. And the yellow bars are people living in remote or very remote areas. And they're much more likely to have a low continuity of care or a moderate continuity of care than people living in metropolitan or inner regional areas. We also looked at the relationship between continuity of care and how much time you spend off work in this paper. Again, the citations at the bottom of this slide. And what we found is that workers who see the same GP all the time, who have complete continuity, had the shortest durations of time off work. And workers with low continuity, who were seeing lots of different GPs during the course of the claim, had the longest durations of time off work. So this begs another question, I think. And the finding is that seeing multiple GPs during the course of a compensation claim is associated with having more time off work. And the policy question is, can and should we encourage greater continuity of care in order to improve return to work outcomes? So the data is prompting these policy questions, I think, and that's sort of another important demonstration for why we would want to do these sorts of things. A couple of other examples quickly, because I'm getting close to the end of my time. At the first one of these seminars, my colleague, Dr. Michael Di Donato, presented some work from this database looking at opioid use and patterns of opioid dispensing in people with low back pain. What he showed, and what I'll repeat here, is that we're able to identify in using this healthcare data, small groups of people, small but significant groups of people who have long-term high or moderate volume use of opioids. So on the left-hand slide, that's the group in the blue and the group in the yellow or orange sorts of colour, which account for about 10% of all the claims for low back pain in this database, result in people having long-term moderate or high volume use of opioids over the 3-year follow-up period that we followed them for here. And on the right-hand side of this slide is what's called a survival curve. Everyone starts as being off work. People in the black line are people who receive no opioids during the course of their claim, and they are more likely to return to work very quickly. People who have short-term, low-volume opioid use, slightly slower return to work rate. And you can see the pattern in people in the 2 groups with long-term, either moderate or high-volume opioid use. They're very slow to return to work and have a much longer duration of time off work. And we've produced some infographics that describe this, and some summaries which you can find on this site. So the short message is that workers who were dispensed opioids had more time off work than those who did not, and the 2 long-term groups had an inordinately long period of time off work. We're talking upwards of over 2 years as a median, compared to a matter of weeks in workers who received no opioids. And again, we've published this work, the citations at the bottom of the slide. Finally, just picking up Mary's commentary on spinal imaging, we've also looked at this. We are able to look at imaging and different types of imaging using this data in our workers' comp schemes. And Again, Michael Di Donato reported this at his presentation a few weeks ago. About 50% of the workers with low back pain in this cohort received no spinal imaging. About 30% received a single episode of spinal imaging during the course of their claim, and about 20% had their spines imaged more than once. And again, we see this relationship with the amount of time people are spending off work. In the no spinal imaging group are much more likely to return to work more quickly, graduating through to the multiple spinal imaging group who have delayed and slower returns to work. And again, this is published work. The citation is at the bottom of the slide. And these extra time off work is not a small amount. We're talking about months and months of extra time off work associated with these use of these sorts of diagnostic procedures in our Australian workers' comp schemes. So that's 4 studies that we've published now that have analysed data from this database. Now my thoughts, having spent the last few years leading this work and looking at this data, is that there is huge potential to unlock the value in workers' compensation payment data in order to better understand the healthcare that's being delivered to workers in Australia and the impact that it's having, particularly on their return to work, but also on other important system outcomes like costs and sustainability. It is very difficult, very technical work. It's taken us years to get to the point where we can describe it to you in 15 minutes here. And we've really just scratched the surface, I think, with what is possible using this data. Some next steps for us, just to finish off, we've got a number of other analyses which are currently underway. We're looking at physiotherapy use in these workers. We're looking at psychological therapy, and we've got some work looking at independent medical assessments. We really want to expand this database. It is a bit old. Some of the data now is up to 10 years old. We want to grow it, have a longer time series, and particularly look at more recent data, look at things like what happened to healthcare delivery to workers' compensation clients during the pandemic. We'd love to involve more jurisdictions and expand the number of conditions and claims that we're looking at some other common or growing issues like mental health condition claims or traumatic injury or other things. We think once we have these data established, there's a really great opportunity here to develop national or interjurisdictional value-based care indicators and then start to track that. So do things like create maps of healthcare variation in Australian workers' comp systems, much like we see atlases of healthcare variation at a national level using the Medicare benefit scheme data, and I've sort of added an example there. So there's a lot that we can do with this data, and we just need the effort and to be continued, I think, to really achieve some of these important things. I'd just like to acknowledge the funders and supporters. Thanks to those jurisdictions who provided their data and their income support, and the funding's come from a number of sources for this study. Thank you very much, and I'll finish there. And Ross, hopefully you've got some questions.
Before we throw to the Q&A, Alex, Mary, I believe you wanted to add something to what Alex was saying?
Just wanted to say that it's fantastic to see there's something happening in terms of understanding healthcare. We've had the return to work survey for a long time to understand return to work influences, but healthcare really has been a black box in terms of what's actually happening. And Alex talks about 2.4 billion in terms of healthcare costs, but healthcare is often doing people harm, and that's not even included in the 2.4 bill. So it's really wonderful to see that there is something happening in terms of trying to understand healthcare, and really commend this work.
Thanks very much, Mary. We'll be back in just a moment with a few questions from the audience. Thanks very much, Alex and Mary. It didn't get past me that you both went over time a little bit, but we'll just have to deal with that as we go. I've got a question from Will Power for you, Mary. Do you think the community could benefit from an updated and revitalised Back Pain, Don't Take It Lying Down campaign?
It worked last time. It was 20 years ago. 25 years ago, people who are around remember it. It was effective, absolutely. Repeated around the world, but less costs and less penetration. It really needs that high level of penetration, absolutely. I think it conveyed the same message to treaters and practitioners, and that made a big difference because they're all on the same page. Patients were telling you, I need to do some exercise, I need to keep active.
And certainly there is research around it that suggests that it's not only the person in pain's expectations that matter in those consultations, it's actually that of the clinicians as well. So it's important to have them on board too, I think. Yeah.
Big time. And much easier to say something to a patient when they're already primed for the message.
Okay, Alex, I've got a question for you. Can you estimate how much of that healthcare that's being provided is, if you like, wasteful?
Yeah, well, fantastic question, Ross. The short answer at the moment in Australian workers' compensation schemes is no, we can't know that. We're really just at the beginning of this sort of process of trying to estimate that. But if we take our estimates from other similar systems and kind of what we know about healthcare delivery generally in Australia and overseas, then we might suggest that up to about 30% of what is paid for and delivered is unnecessary and is not doing any good. And as Mary suggests, we also know that some things that we do in healthcare systems actually do harm. So, that would be sort of, reasonably defensible estimates, I think, based on studies published in other healthcare systems. And there's no reason to suggest that the healthcare in our workers' comp schemes is going to be much different to what we see internationally or in other Australian sort of healthcare settings. So, yeah, there's a huge potential to reduce waste at a minimum here. If 30% of 2.4 billion is a lot of dollars, not least the potential benefit in terms of savings for other costs in our schemes and benefits to individuals in terms of improved health if we can also reduce those harmful practices.
So, Mary, sorry, go ahead, Mary.
Just a quick comment from me. We're talking money here, but the money translates to people. And that's a lot of poor treatment for people and not helping them get better. Sorry, Ross.
Yeah.
Well, I was just going to say, Mary, that I guess, one approach to potentially reducing that waste is to actually look at the person. And that's what the biopsychosocial model is all about. But as you mentioned, we've been talking about it for years. And trying to adopt that model over the medical model. So what's missing? What's taking it so long?
Yep. We need a system approach. As Jeff Boz at Basel says, standards are contagious, or he says high standards are contagious, but standards are contagious. So if somebody's doing it in a kind of an ad hoc, haphazard, or not doing it, then that influences the next part of the next person in that treatment approach. So we need a systematic approach. We need a systematic approach for triage, assessment of the biopsychosocial issues, help, coaching, therapeutic counselling, whatever you call it. We need a lot of training. It's hard to actually speak to people in a way that engages them and helps them understand. Done properly, it's actually not that hard, but you need to have the smarts of how to do it. So we need training. We need skilling of allied health practitioners, case managers, the medical profession. We're probably worse than anyone in the medical profession at focusing on the biopsychosocial model. So we need it to become systematic. It's not uncommon to see, questionnaires, a short form of REBRA is our most common one used in Australia, identifying psychosocial issues that we just kind of don't address. There might be a bit of a talk from the physio, but we're not doing it properly and systematically.
So another question's come through, which you've pretty much answered it with your response there, Mary. It's a question from Sovan Day. I hope I pronounced that correctly. Education to primary healthcare professionals, including GPs, physio, chiro, and OT, is needed to keep all in one page, which is the hardest thing I face for a return to work with back pain, as each take a different approach to treat. How can this be improved? And I think, Mary, you've answered that with a system approach to it. I think I would, as part of that system approach, there needs to be an emphasis that actually providing good quality, high quality advice, not just giving advice, but making sure it's high quality, has to be a part of that systematic approach.
Absolutely, very much so.
So, Alex, like you said, there's lots we can actually harness from this data. Why has it taken so long to actually put together the data in a way that that we can actually start to gather some of these insights and ask the next questions?
There's all sorts of reasons, Ross. I think most of this, in practice, this data sits at either a jurisdictional level or beneath that with individual insurers, in some cases large employers. And so what we have been trying to do is aggregate all that up into a sort of single database that enables this multi-system, if you like, a multi-state view of what's occurring. There's just heaps of practical and technical challenges with doing that. I've mentioned some of them during my talk. The fact that we don't have any standardised approach to coding healthcare delivery in our workers' comp systems is kind of surprising, I think, given how much we spend on it. We have some standards for things like occupational and industry coding, and we have a standard approach for how we define what an injury is, called the TUCS system, or how we code it at least. Yet we don't have the same for healthcare. Every state and territory does it differently. And so one of the practical challenges is taking all that different information and turning it into something that is consistent across those different states and territories. And that's taken us a number of years to be able to do that and to develop a sort of an approach that allows us to make sure we're comparing apples with apples rather than comparing apples and oranges and pineapples and bananas and all sorts of other things. And look, I think some of the other challenges are things like political will. I mean, most of the people or organisations who operate these systems are most concerned with what's going on with their system, and quite rightly too. But it can be helpful to look over the fence sometimes and to try to learn from others and learn if what you're doing in your jurisdiction is the same or different to what's going on in other parts of the country. And we have lots of examples in healthcare settings where those healthcare variation maps or comparative studies have actually led to quite significant insights that enable changes to occur. Particularly, you might think about sort of the American healthcare system, not that I hold that up as a gold standard, but they do a lot of that comparison, comparing themselves to other countries because they tend to be pretty poor on most sort of markers of healthcare delivery. So there's huge potential to do it, but we have to have the sort of political will to do it. And that can take a fair bit of courage, I think, because you may not get the answers that you're looking for.
And then I guess following on from that, Alex, is there that opportunity to see then, well, what happens beyond some of these jurisdictions? So when someone might finish their workers' compensation journey, for example, do we know much about what happens in terms of health outcomes after that?
Oh, the short answer is no, we don't. But tune in next week, Ross. I feel like you're setting me up for to promote our seminar next week. So
I'll open the door for you, Alex.
We're starting to. So next week, same time, same place, 12:30 on Thursday next week, we have a seminar where we're describing a study where we've linked workers' compensation data to Commonwealth healthcare data and also hospital data, which has allowed us to follow people up and look at healthcare use and other things after workers' compensation benefits stop. But apart from that study, I'm not aware of anything in Australia, and only 2 or 3 things internationally that have ever looked at that in a workers' comp setting. So no, we tend to manage these schemes in isolation and not think about how they interact with the other systems in society that we know our workers are interacting with, which is a great shame, I think, because we only ever see part of the picture.
Great. Well, thank you very much, Alex, and thank you, Mary, for your great presentations today. Please join us in just a moment. We'll give you some more details about the next seminar coming up. Thank you for attending the 4th Compare Project event in the 2022 Healthy Working Lives seminar series. We'll be hosting another 2 free events until June, and you can register for them on this platform. Now, we've got 2 events coming up in the next couple of weeks. The next event will be on the 12th of May, and there'll be one following on the 19th of May. And so we've got them coming up in terms of what happens to workers with long duration compensation claims. So we'll hear from Dr. Daniel Griffiths and Luke Sheehan from the Healthy Working Lives Research Group. We hope to see you there. Thanks for joining us.